This is Caroline Brotzki. I'm a fourth-year medical student at the University of Buffalo, taking the rotational course of diagnostic imaging for the primary care physician, and I have a case to present. This case is of a 19-year-old African-American male. He was a pedestrian involved in a motor vehicle accident in July of 2016. The patient reported that he was riding a bicycle when a car struck him on the left side, hitting his ankle and his knee and throwing him onto the ground. He subsequently fell on his outstretched left hand, and he reported no loss of consciousness and was taken by ambulance to ECMC. The time immediately following the accident, he complained of left-sided pain, including his shoulder, his wrist, his ankle, and his neck. There were radiographs taken at ECMC, and after evaluation, he was discharged home from them with prescription for ibuprofen for the pain. In the days following the injury, he continued to have pain, with the primary sites being the radial side of his left wrist, as well as his neck and his back pain. He reported some gripping, pain with gripping, with extending the wrist, and with lifting objects on the left side, but he denied any numbness or tingling. The patient began treatment for the back and neck pain and was referred to an orthopedic specialist for the wrist pain, where radiographs were performed, and he was diagnosed with a scaphoid fracture according to the radiographic findings and was placed in a short arm cast after that. Following the evaluation with the images and the cast placement, the patient underwent wrist surgery at the beginning of October. During this surgery, there was found to be non-union of the scaphoid fracture and avascular necrosis of the proximal pole of the scaphoid. Additionally, they found a scapholunate ligamentous tear and an intra-articular loose body, which was removed from the area of the fracture. In the surgery, he underwent open reduction and internal fixation and had an autologous bone graft placement from the distal radius of the same hand. A screw was placed to fixate the proximal and distal poles of the scaphoid, and following the procedure, he still had some pain as he was healing. He reported some aching and stiffiness of the wrist and pain with extension of the fingers and thumb. In additional history, the patient is a full-time student. He's not currently employed. He denies alcohol, tobacco, or illicit drug use. He has no drug allergies, but does have seasonal allergies. And he reports taking no other medication than the ibuprofen he was originally given for the pain. His past medical history is significant for asthma as a child, and he had a left ankle fracture 2 years ago during a football game, which was also surgically repaired. On physical exam, the patient's vitals were a heart rate of 80, blood pressure of 128/62, and a respiratory rate of 12. He seemed to have some discomfort, but was in no acute distress. His cardiac exam revealed regular rate and rhythm and no murmur. On pulmonary exam, all lung fields were clear to auscultation, and his breath sounds were equal bilaterally. On musculoskeletal exam, his left wrist was casted at this time. This was post-operative. There was no gross deformity of swelling seen of the fingers. His grip strength was 70 pounds with the right hand. We were unable to test this on the left due to the cast. His pinch strength was 9 pounds with the right hand and 1 pound with the left hand. Range of motion was normal in the right wrist, and we were unable to test range of motion on the left wrist, again because of the cast. The left shoulder exam revealed a positive Neers test for impingement and a positive Hawkins test. Cervical compression produced left-sided neck pain. And on the neurological exam, sensation was intact and equal on all 5 fingers bilaterally. Bicep and tricep deep tendon reflexes were 2+ bilaterally. So, we can discuss the images that this patient received. The first few images are preoperative. This one here is an AP view x-ray of the left wrist. You can see here there is a displaced scaphoid fracture with a 2.6 millimeter fracture gap present. There are also sclerotic changes of the proximal pole of the scaphoid, which may represent avascular necrosis in this image. The second image is an oblique x-ray of the left wrist. Again, we see the minimally displaced scaphoid fracture right here. The sclerotic changes can also be seen in the proximal pole of the scaphoid, but this is a little more difficult to see in this view because there is some overlapping between the scaphoid and the other carpal bones here. But we can see that the radius and ulna are relatively normally aligned, and the carpal bones demonstrate reactive bone throughout them. And the scapholunate joint has a normal space here. One of the diagnostic criteria for a scapholunate ligamentous tear is seeing increased space on a plain radiograph between the scaphoid and the lunate. 3 millimeters or greater of space is diagnostic of a tear on an x-ray. This is not visualized here, but it should also be noted that plain radiographs are not very sensitive for this kind of diagnosis. This here is a lateral x-ray of the left wrist. Again, we see the minimally displaced scaphoid fracture. It is a little more difficult to see the sclerotic changes and the displacement of the fracture in this view because of the overlap of the other carpal bones. This patient was also evaluated with CT scans following his x-rays. But before I move on to that, there was one more plain radiograph here. This radiograph is this x-ray shows ulnar deviation of the wrist, which is done to increase the space between the scaphoid fracture to see if there's any more displacement when this type of stress is placed on the wrist. And here we can see that the displacement of the fracture looks a little bit larger compared to our original AP view with the ulnar stress placed on the wrist. So moving on, this is the first image of the CTs that were performed on the wrist. This is an axial cut CT. This also shows the displaced fracture in the scaphoid right here, and we can also see the sclerotic changes of the proximal pole of the scaphoid in this cut. Additionally, this is a second axial view of the wrist. This just shows a different cut through the fracture so that we can see kind of how irregular the cut is. And again, we can see some darkening of, or I guess brightness of this side of the scaphoid compared to this side, which may represent the avascular necrosis. This is a coronal CT of the wrist, and here the fracture is very obvious, and again the sclerotic changes are very visible. You can see how much brighter the bone is on the proximal end compared to the distal end of the scaphoid. Again, when we look at the space between the scaphoid and the lunate, it is not obvious on CT that there may or may not be a scapholunate ligamentous tear. Like the radiographs, what is diagnostic of this type of tear on a CT scan is greater than 3 millimeters of space between the articulation of the scaphoid and the lunate bones. This was not visualized on any cuts of the CT, and again, CT is not very sensitive for this type of evaluation because CT is better at evaluating bones than it is soft tissues. If we wanted to be sure about whether or not there was a ligamentous tear present, we would order an MRI. This was actually considered along with the images that were performed on this patient, but because it was so clearly obvious that he had a displaced fracture and needed to go to surgery, it did not seem like it was worth the money to order an MRI. So that wasn't done. This is a sagittal view CT, and here's the fracture line here that we see with the proximal pole showing some of the sclerotic changes and the distal pole of the scaphoid right there. Now these images are post-operative. We can see that there is a screw and pin placed in the scaphoid longitudinally. The screw is fully encased in the scaphoid, and the screw is holding together the two ends of the scaphoid to help with the displacement. You can also see the area where the bone graft was taken from the distal radius here. And here is a lateral view postoperative x-ray. Again, we see the screw fully encased within the scaphoid, and we also see the pin in the scaphoid there. So everything looks like it's right in place following surgery. So those are all of the images that we ordered on this patient. So moving on, if we talk about the differential diagnosis for a scaphoid fracture, this would include a wrist sprain, a distal radius fracture, which would be much more common in the elderly or children because the radius is much weaker than the scaphoid in these age populations, versus this 19-year-old male in which the scaphoid is the point of least resistance in this age group. Additionally, there also may be another carpal fracture instead of a scaphoid fracture or in addition to a scaphoid fracture within your differential diagnosis. But this patient was diagnosed from the very clear fractures seen on plain radiographs and on the CT. He was treated, as I said, with surgery, with a screw placement and the autologous bone graft that we see. As I stated before, in surgery, there was also found to be a grade 2 scapholunate ligamentous tear. This was not visualized on the plain radiographs or the CT scan. As I said, it would have been easier to visualize such soft tissue damage on an MRI, but this type of test was not ordered. However, because this patient had surgery, this type of injury was easily diagnosed during the surgical procedure and was repaired. It is extremely important to repair a scapholunate ligamentous tear in this type of injury because if this is not repaired, it can lead to disruption of the entire proximal carpal row, and this ultimately may lead to a complication termed scapholunate advanced collapse syndrome. This is a pattern of degenerative change in the wrist, which is caused by poor articulation and alignment between the scaphoid, the lunate, and the radius. This can cause chronic wrist pain and sometimes in itself requires surgical intervention down the road if conservative measures fail, and this would of course be more complicated surgery because it would be because of chronic pain and degenerative changes versus the surgery to repair the fracture in the first place. Also, it is noted that this patient had a vascular necrosis of his scaphoid. This was visualized by the sclerotic changes that we talked about on the images. And this was also visualized and debrided during the surgery. This is one of the most common and most feared complications of scaphoid fractures. It is more common in a scaphoid waist fracture with displacement, and this is why the treatment for displaced fractures is always surgery. This avascular necrosis can lead to non-union of the bone, and down the line can lead to osteoarthritis of the carpal bones and the radiocarpal joint. The reason that it is so common to get avascular necrosis and a scaphoid fracture is because of the tortuous blood supply that the scaphoid receives. The scaphoid receives blood to the distal end of the scaphoid, which then backtracks to the proximal portion of the scaphoid. So the only way that the proximal portion of the scaphoid receives blood is by getting it as a continuous supply from the distal scaphoid. Therefore, if there is a fracture that cuts off the blood supply from the distal scaphoid, coming from the distal scaphoid heading to the proximal scaphoid, then the proximal scaphoid will lose its blood supply and undergo avascular necrosis. Now, this patient did have a displaced fracture. However, patients who have non-displaced fractures can often be treated with conservative treatment. They can get a short or long arm thumb spica cast for immobilization for 4 to 6 weeks. There has not been shown to be a significant difference in short or long arm casts in patients. And as long as there is no displacement seen, there is a rather low risk of non-union. However, if there is any displacement seen at all, that is always a significant reason to get surgery in these patients. Additionally, patients who do not have displacement of the scaphoid fracture but want to return to work earlier or assure quicker healing, they also have a choice to undergo surgery. The 2-year follow-up for patients with non-displaced scaphoid fractures is the same with and without surgery. However, there is quicker recovery for patients who receive surgery than patients who do not. So that is up to the discretion of the patient. So it is clear to see that this patient had a rather complicated course, considering the bone that he fractured was so small and may seem insignificant to some. It was very important for him to get surgery to prevent chronic degenerative arthritis and chronic wrist pain down the road. And it was also important for him to get surgery due to the tear in the scapholunate ligament, and also because of diagnosis of this ligamentous tear, which was not visualized on the plain radiographs or the CT that were ordered for him. So that concludes this case. I hope that you learned something.